Hey team, welcome back to our third part of our discussion on kidney and bladder conditions. Okay, so we're starting out here with chronic kidney disease. Chronic kidney disease, despite sounding like a state, it kind of is, but it's really more a marker of dysfunction. So what you have here is a chronic degenerative condition in which the kidney was in this green area here, and then it begins to deteriorate, and it is going to keep sliding, mind you. Once you get onto this path, once you pass this mark right here and it keeps deteriorating, then that means you're in a state of chronic kidney disease. They know that this is present by measuring from labs the glomerular filtration rate. The glomerular filtration rate, the GFR, is a very old tool used for gauging the amount of injury that a kidney is experiencing. Remember that the glomerulus is the structure that's part of the functional part of the nephron of the kidney. So if it's not doing its job very well, then that indicates the entire kidney is not functioning, right? GFR as a lab value has a really dark history that has changed in real time in the last 4 or 5 years, which was championed by, interestingly, Black medical students. So it used to be, there's some supplemental material on your Canvas about this, but it used to be that there were race-based norms in GFR, and because the norms were offset for individuals who are Black, it basically meant that the amount of CKD was underestimated in individuals with chronic kidney disease, and so they weren't getting care as quickly, and they weren't qualifying for kidney transplant as quickly as they should. So again, the history of medicine is rife with racism. So if you want to read a little bit more about that, you can. Be aware that it's possible that you may have a hospital that hasn't updated with the times, and you might still see that little parentheses AFAM after the GFR. That shouldn't be happening, but you might still see it, or you might have somebody who is probably due to retire and gripes about the change. So the modern age is here. We need to do better. GFR, though, in general, works pretty well. And when that starts to get low, they initiate aggressive medical treatment. So as the kidney starts to fail, you have supplemental help from dialysis. So this is when a person qualifies for dialysis, when CKD is present. Ultimately, they will need a renal transplant. The etiology on CKD is variable, but there are 3 classics, and I do want you to be familiar with the 3 classics: type 2 diabetes, type 1 diabetes, and hypertension. We'll go more into why diabetes can cause kidney injury when we get to metabolic endocrine disorders. In essence, because the pancreas and the blood sugar levels, all of that function is altered, the kidney bears the brunt of the damage. So over time, it can no longer handle it and it begins to fail. How do they know that the kidney is injured? They'll do an ultrasound to see if the blood is flowing correctly through the structures it's supposed to flow through. A CT will also help diagnose renal stones and things like that, see if those are present. But otherwise, what you have here is, again, because you're in a state of chronic injury, guess what? That means inflammation is occurring. So structures in the kidney that were functional are being replaced by fibrotic tissue. And scar tissue doesn't function. It's just a placeholder to maintain the anatomical structure. But as that scar tissue / fibrosis builds up, that process destroys the kidney. Now, the progression speeds up when other things are wrong as well. So it's important to realize that it's a multifactorial thing. But in essence, what you have here in the pathophysiology is chronic injury results in chronic inflammation, results in scarring. The scarring replaces what was previously functional tissue. Scar can't function, so you have decreased kidney function. So now let's get into the replacement. So the replacement for the kidneys is dialysis. Let's look at that here. So what you have here is a person has a graft placed into them, and it serves, so here it is right here. So they have a fistula, and that takes over, and the machine cycles their blood. It takes out the waste products, corrects the salts, and cycles it back in. So it's got a way in and a way out. So see, blood comes out to the dialysis machine, blood comes back in from the dialysis machine. There's different locations on where they will put the fistula, and it's why you always have to check for blood pressure, cuff safety, because you really cannot take blood pressure on the arm that has a fistula or an atrial venous graft for dialysis. So what is dialysis? It's what happens when the kidney enters end-stage failure. So CKD, they are probably on it, but once it comes they might be, they might not be, sometimes not always, but for sure, if you hit all the way into end-stage, so that's this this marker here, right here, when you hit failure, it's definitely happening. So again, what does it do? It removes all the waste products, excess water, keeps everything from building up, gives them safe levels, and it also maintains their blood pressure because that function is no longer processing well in the kidney that's, not working anymore. Some people live for about 10-15 years once dialysis starts. The National Kidney Foundation says that people can live upwards of 20 to 30 years. Know that dialysis is sometimes, the big formal term is hemodialysis, so you'll see it in documentation abbreviated as HD. So don't go thinking that's Huntington's disease. That's just for us neuroheads. HD is for most all healthcare providers, hemodialysis. So 5-year survival, though, in general is not great. Again, it's because a critical organ is failing. So basically, once someone is on dialysis, they're hoping that they can get a kidney. Okay, so when do you need dialysis right away? All of these things are true, but the big one I want you to be aware of, the one that's bolded, that's in red, that has the red flag here, is if they have an altered mental status. If somebody has a dialysis indication, in other words, they need to go to dialysis and they didn't go, all of those waste products are built up, including all of those solutes that we talked about, all the electrolytes, and their mentation is going to be off. So if you have a patient that you know has a fistula, that you know has a dialysis need and didn't go, and they're confused, nope, they get to go to the emergency room right away. I have had to send people, this is a thing, again, an outpatient. I'm not pro bono outpatient, typical insured, they have resources, outpatient physical therapy. And for whatever reason, sometimes people will skip dialysis and come to physical therapy. I don't know why that's a thing, but it totally is. So if that happens and your patient shows up and is confused and can't remember your name and you've been treating them for the last 2 months, whoops, we're going to the emergency room right now. So I've only had to send people a handful of times with this, and they usually show up with their adult child who's really frustrated. But yeah, no, they need to go. Okay, so who is a candidate for a kidney? Well, that's somebody with CKD that devolves. They devolve into end-stage renal disease. So it's the best treatment option for end-stage renal disease, or ESRD, because you're way more likely to survive than you are on long-term dialysis. This transplant goes really well. Notice the survival rates. Look at that. I mean, it's really, really high. It goes great. They do have to be on transplanted organ rejection meds for the rest of their life. So these are folks who are probably, wearing a mask out in the community still. There's an organ allocation network, UNOS, and I have some material on your supplemental for this. So it goes pretty well, actually. So here's where they usually do the incision. Not always, but often. Sometimes they'll go a little bit higher up onto the flank. But yeah, it goes really well. And then what's kind of interesting is they actually put it down real low in the hip. I mean, that's not really where the kidneys are. The kidneys are up just a little higher. And so you can see, here's the diseased kidneys. They just leave them. So what you'll hear, and you can see it on CT scans, is if somebody has had 2 or 3 kidney transplants, which is rare, but you do see it, you'll just see this little chain of jelly beans coming down, and then the big healthy one, which is kind of funny. So yeah, there's the scar sites. Sometimes they go through the side. You can see this person's had revisions, that sort of thing. So this is an actress who's had to have repeated ones. So see how she has an incision right here? That means something went wrong. So anytime you see one and then multiple lines, something went wrong and they had to go ahead and do full open abdominal surgery. All right, let's kick over to genitourinary. So we're going to come all the way down on the structures here we're talking about. There's really only a couple conditions of note. And a big one, a big one is UTIs. Oh my goodness. You would not think that an infection in this structure would be so incredibly important to know, and yet it really truly is. So you have 2 sites that are both counted as a UTI. So you can have all the way down really low an infection of the bladder in the lower urinary tract, and that's cystitis. And then you can have an infection of the kidney and the upper urinary tract, and that's pyelonephritis. Pyelonephritis is more dangerous because if the infection makes it up into the kidney, guess what goes through the kidney? Blood. So this is why it's so dangerous. If the infection that's in the urinary tract makes it up into the kidney, and then the infection makes it from the kidney into, like out of the organ and into the blood itself, then you have urosepsis. And that's why this is so dangerous. So especially as folks get older. I mean, you may have had a grandparent who's admitted to the hospital for UTI, and you might think, wait, why? This is why. Because it actually wasn't so much UTI as it was pyelonephritis, and then the bugs got out. So really bad news. 2 different presentations to be aware of, although they're honestly pretty similar. So in cystitis, this one I think if people are younger, they might be more familiar with. This is painful urination. So the thing people say is that it's like peeing broken glass. It is sharp, very, very painful. They need to pee frequently. We're talking probably like 2 or 3 times an hour is not unusual. But at the same time, they sit down, they try to use the restroom, and they can't. They just can't get the flow to start. But they need to go right now. So it's urinary hesitancy with urinary urgency. It's frustrating. So there might be a little bit of blood in the urine, hematuria, not like a ton like there would be in other conditions. This should not produce a full tilt Coca-Cola colored urine. There might just be like a few drops. Pyelonephritis may have some of those symptoms, and it gets worse. It comes all the way up into back pain. They usually are nauseous and vomit. They get chills, they shiver, and they'll have a fever. So basically, if you have all of those urinary issues and a fever with back pain and nausea, vomiting, we actually need to maybe consider going to the emergency room. Yeah, so that's really bad. The pathophysiology, a bug gets in. Sexual intercourse is a common cause. One thing that I have seen pretty frequently that you wouldn't think would be an issue, I don't know if it's generational, older folks wipe the wrong direction. So I'm not sure why that's a thing, but they will wipe from back to front, and so that's sometimes a factor. And then sometimes they have no idea. Honestly, they think it's just anatomic, particularly in cisgender women. It makes sense. I mean, the ureter is right there, and the anus is right there, and it just happens. You didn't do anything wrong. So that's a thing. Now, if somebody does have recurrent UTIs, you definitely want to refer that out. To be perfectly honest, that needs to go to an OB-GYN for assessment. But if it helps, frequent voiding is known to decrease the risk. Otherwise, they're just going to give them antibiotics. So if you can catch it earlier when it's still lower down and at the cystitis level, that's good. Meds can knock that right out. So again, on the etiology, just pathologic bacteria make it up. Women are more likely because the urethra is shorter. The most common bug, and this is how you know it's probably coming from the anus, is E. coli. So E. coli is in your fecal matter, which, I know that's super gross, but that's just how the body is. That's the layout. It's kind of crazy. So women more than men, you definitely want to know that. So 2 in 5 women will have at least one UTI in their lifetime. So that tells you that's obviously anatomic, right? Now, for the 1 in 10 that get an infection yearly, make sure you refer that out to the OB-GYN or the PCP. Risk factors. So if somebody uses a catheter to urinate, and the classic in this is going to be folks with neuro conditions where their bladder function, the neuro elements of their bladder, voiding and retention of of urine as it forms in the bladder, those 2 elements are often off in an individual with a neuro injury, the classic being spinal cord injury, and they may have to use a catheter, which is a device that goes up the ureter and into the bladder and helps them drain urine out without urinating. So if they use a catheter, though, because you're introducing a foreign object into the body, even with sterilization stuff, the odds of getting a bug up in there and you didn't mean to is decent. So that's a risk factor. Constant use of antibiotics is also a factor because you're, altering your microbiome out there and just making it more likely that bad bugs get up. Diabetes is another one. And then it's really common after kidney transplant, which makes sense because you're on immune suppressant medications. So really important to be aware of UTI and PT. So the houses that know this are geriatrics, pelvic floor, and neuro, again. So these are the ones that have to be the most familiar with it. So you want to be capable of screening it. So what I have here are basically all the signs and symptoms of a UTI with a couple of little extra things. That urinary urgency, the need to use the restroom, persists into the night. So they have nocturia. And sometimes they get a little bit of sensitivity, like around their flank and regions in like the perigenital region. And that hyperesthesia, sensitive to touch, can be a rather striking. Otherwise, these are all the same things that you saw before with a couple of extra terms. So they might have a finding in labs called pyuria. We're not capable of saying that pyuria is there, but pyuria is excessive white blood cells in the urine, so the urine will appear cloudy. And that's why I want you to be familiar with the fact that cloudy urine means go see the doctor. And then dyspareunia is painful physical intercourse if somebody engages in penetrative intercourse. So that's something to keep in mind. Any of those complaints, I've added on a few extra elements that PTs tend to interact with, like patient complaints. This is how you want to know to refer them to the right provider. Okay, and this is just me giving you a little bit extra on catheter, how I was telling you some people have to use a catheter. This is just me demonstrating that. You don't need to know this slide. It's kind of just for those of you who are thinking of going into neuro. And so we have the two anatomies, like how that looks when somebody uses a catheter. So I just kind of want to emphasize to you, if somebody has to do catheterization, they call it intermittent catheterization because it's like on a schedule. Check this out. It's about every 6 hours. That's crazy, right? That's really tough. And so if somebody has neuro, they have to do all of this like in the bathroom, and like their hands maybe don't operate properly because of their neurologic injury. It's really hard to do. So UTI is almost like a little bit, not quite guaranteed if somebody has a spinal cord injury or another neuro injury that takes out their neuro control of their bladder. And so just, have sympathy. And if they get a UTI, they didn't do anything wrong. It's just really hard. And then the last one, bladder cancer. The big thing here is to catch this early. This is the most common issue in the urinary tract is cancer of the bladder. What's interesting is its presentation is variable. So your two books actually contrast on the symptoms. So the main thing that they will say is that it is painless hematuria. In other words, there's blood in the urine and it does not hurt to urinate in the vast majority of patients. Now, that means 15% it does hurt to urinate, but you would think, in general, if there's blood in your urine, go see your doctor, okay? Pain doesn't have to drive you in. The visual of there being red in the toilet bowl should drive you in. So we're going to go with painless hematuria because it's far and above more common. And that's what I have also heard far and above more with my patients as well. So textbook matches with actual practice. It affects men more than women and a higher age after 55. So I do want you to know that. Older gentlemen, that's who's much more likely to have this. So etiology, it runs all over the place, but unfortunately a workplace exposure to industrial solvents is one of them. Smoking is pretty common, and then mutations. So that's basically the etiology of cancer. I don't need you to know those stages there, but note how aggressive that is. If they have stage 3, they might not make it for a year. So it is really, really important to catch this early. And there's really just one way to catch it: an older male who has blood in their urine. There you go. It's that simple. But working in the cancer hospital, a frequent story was a patient. Because if you're hospitalized for cancer, it's worse than if you have cancer at home, right? Like you're more medically fragile. And so with the ones where the course of the disease was going even worse, they would sometimes say, yeah, I was bleeding, in my urine sometimes for a month or two. Oh my God, that means they're sliding through the stages, right? But look, here's the good news. If you catch it super early, it's only 5% mortality within 1 year. That's great, right? I mean, it jumps very quickly, but if you can catch this early, then that's really, really good. You're saving their life. So that's why I have that there. And then this slide is a little bit of something for your second year when you go through your clinical management courses. And it's something to think in mind for, like, these are the questions that you ask all of your patients to review systems. And typically this is on your intake paperwork. So if they have some sort of issue with anything urinary related, these are the questions you could consider asking. And notice how they really do capture a lot of the things we were talking about. All right, team, I'll see you in class.